Thank you, Chairpersons, and good morning to all the delegates here. Thanks to the organizing committee for having me over for this particular talk, which is very interesting. I'm a late entrant to intrapartum ultrasound. I picked it up in AICOG, Kolkata, where Dr. G.G. Selvan spoke about this, and then I was so impressed that I came back and started to do intrapartum ultrasound, and here I am talking about it. So in the next few minutes, I'm going to talk why intrapartum ultrasound, what can be assessed, how to go about doing it, what to look for, and what are the advantages. And now that you know, what else is available for us with intrapartum ultrasound. Now you all must have known, you all must have seen that the digital assessment in labor, the PV that we do to assess in labor, is quite often painful. Women abhor the digital assessment. It is associated with ascending infection also, both for the mother and for the fetus. And it's largely subjective. I say 3 centimeters, she says 4 centimeters. And she says a full dilatation, somebody says, no, there is a rim that I feel. So it's very subjective. Now, therefore, we know that in labor, if we have to make decisions, this is based on objective evaluation. We need to be very certain about what we are seeing and finding. It can't be just my intuition, I think she will progress and I think she may not progress. That doesn't work. Intrapartum sonography is far more accurate than digital examination. It's not technically demanding. It's not rocket science. Anybody can do intrapartum ultrasound, at least obstetricians definitely can do. It provides high reproducibility, and what I see is what you also see. So therefore, the difference is very little, and neither increases the rate of ascending infection nor causes discomfort to the patient. So it has got all the advantages that you can think of. Now, what does evidence say? Now, this is what we all feel. What does evidence say? It says that intrapartum ultrasound is more accurate diagnosis of fetal station, fetal position, fetal attitude, and the progression of labor. It performs better than clinical examination in predicting the occurrence of vaginal delivery among women with a protracted active phase. Those who have a long first stage, long second stage, which are the women who will deliver vaginally, which are the ones who probably go in for cesarean section. And especially when we are doing instrumental delivery, of course, it's become a dying art now. Those of us who are still doing instrumental delivery, it is very, very comforting to know that whatever we are doing, the application, etc., is absolutely right. Now, it could be used right from induction of labor to pre-labor to the first stage, second stage, and third stage. What we are already doing, of course, many of us have an ultrasound machine in the labor room, and what we are already doing is once in a while checking the live whenever we have a doubt in the labor room, checking the fetal heart. Especially for twins, we know what is the presentation and position of the leading twin, and after delivery of the first one, we want to know about the second twin, and delivery of the placenta for manual removal, etc. Many of us are using it, and for obstetric anal sphincter injury. What we need to start, this is something that we are already doing. What we need to start is identifying fetal positions on a regular basis, prolong first and second stage of labor, use it there, and before an instrumental delivery, definitely consider using intrapartum ultrasound. What we can probably do in the future is use intrapartum ultrasound for induction of labor. To know the cervical dilatation, instead of doing a PV, we could do it with an ultrasound probe. And instead of the regular partogram, we might probably come up with the sonopartogram. So where can we use intrapartum ultrasound? Like I told you, objective assessment of fetal head malpresentation, slow progress, arrest of labor in the first stage, second stage, and before we do an instrumental delivery. Now, what are the requirements for this? Machine is a simple 2D machine. Sometimes your machine doesn't work, some probe doesn't work, or some part doesn't work, it doesn't take measurements. Take them to the labor room, you can make use of it there. abdominal probe or the transverse curvilinear probe. It's not the vaginal probe, it's abdominal probe that is used. Who is the person who is doing it? It's you, not the sonologist. Any obstetrician gynecologist can do the intrapartum ultrasound. Technique of intrapartum, we can do it transabdominal and transperineal for looking at the position and the progress of labor and predicting labor. Now, you can hold the abdominal probe just above the symphysis pubis. This is how you do a transverse plane ultrasound, and for a sagittal plane, you hold it vertically along the midline, along the linea nigra. So then the landmarks that you get to see here on the fetus would be the midline structures. You get to see the orbits, you get to see the cerebellum, vertebrae, etc. Now when you're doing a transperineal or translabial ultrasound, it is the same thing. Hold it across horizontally, parallel to the ground, its transverse plane and the sagittal plane. Sometimes you will have to manipulate the probe with a little lateral movements until you get to see the pubic symphysis. The fetal skull are already seen and there is no shadow from the pubic rami can throw shadow sometimes. So make sure that doesn't happen. Now most commonly what is used is for the head attitude, whether it is completely flexed, whether it is deflexed, etc. The degree of head flexion in the metal pelvis can be made out. And this is the angle that you get to see with this angle that is drawn between the spine and the skull, that is the occipital region. You get to know whether it is well-flexed head or whether it is a deflexed head. Now these are my pictures, they are not the best of the pictures, but you can beautifully see here, this is the attitude of the fetus here, and then as labor progresses, you can see the flexion has increased. Now visual confirmation of the fetal head malpresentation, deflex cephalic presentation or asynclimatism is a major cause of obstructed labor and cause for 1/3 of cesarean deliveries for arrest of labor. That is why it is important that if we are able to do an ultrasound at the beginning of labor and if you are identifying a deflexed head, it is worthwhile following it up. Now the fetal head position, is it occiput anterior, is it occiput posterior, is it transverse, LOT, ROT, that can be made out very well with the ultrasound. The location of the fetal spine and occiput are used as anatomic landmarks and related to a clock face. Now if it is anywhere between 10 o'clock and 2 o'clock, 10 o'clock and 2 o'clock, then you call it as an occiput anterior. That is, if the occiput is anywhere between this region, it is occiput anterior. If it is between 2 and 4 here, 8 and 10, then it is occiput posterior and likewise the transverse on either side. Now with the transabdominal ultrasound, you know this is an occiput, this is the spine, this is the occiput. Since the occiput is facing the probe here, you know it is occiput anterior. Now this here, when you are placing the probe on the abdomen, you see the eyeball staring at you, you know definitely this is an occiput posterior. You don't need a sonologist to do all these things, isn't it? And definitely it is better than our palpation. Transabdominal ultrasound imaging in transverse plane for locating. First you locate the spine. So this is how the spine looks. So when you know this is the spine, this is occiput anterior. The spine is here at the back away from the probe. So this is occiput posterior. Now you know the spine is at 9 o'clock position here. This is right occiput transverse. Here it is at 3 o'clock position. So you know it is left occiput transverse. Now what do we measure to check the progress in labor? We always said that it can be used to check the progress of labor. You need to look at the midline angle. You need to look at the angle. There are so many parameters. Each one has come up with a parameter, but 4 are important. Midline angle, angle of progression, head perineum distance, head direction with respect to pubic symphysis. These are 4 parameters. Of these, I would say 2 are very important. One is the angle of progression and next is the head perineum distance. You should start doing it in your practice and you will realize how useful it is. Midline angle is, it gives you an idea of the fetal head rotation. It's the angle between the fetal midline, it's the angle between the fetal midline and the anterior-posterior axis of the pelvis. So if the angle is less than 45 degrees, you know the head is well rotated. If it is more than 45 degrees, you know that rotation is still to happen or has not happened. Now, angle of progression, see this is the angle of progression. You look at the longitudinal axis of the pubic symphysis. This is the pubic symphysis. This is the fetal bone, cephalic portion. You draw a tangent from there and this becomes the angle of progression. Even at first look, you know it is an obtuse angle, that is more than 90 degrees. So, more obtuse the angle, the lower down the pelvis, the head is. Assessed by a transperineal approach, easiest to obtain, easiest to teach and fastest to use. No need of expensive ultrasound units, no need of 3D software capability, no need for meticulous training or offline instruction volumes, etc. So this is what I told you. After full dilatation, like after the full dilatation of the cervix, if the angle of progression is more than 120 degrees, you know the head is engaged by clinical examination. In all cases in which the angle of progression exceeds 120 degrees, a consistent increase if it is there, then you know that this will lead to a spontaneous vaginal delivery. Next is the head perineum distance, and this is the simplest and the easiest of the measurements. You hold a probe like this translabially or transperineally and direct it, and you get to see the pubic symphysis here. You measure the distance between the pubic symphysis and the skull. So then this portion will be the skin here, and so this is the skull and this is the head perineum distance. Now in early labor, this is one of my pictures. The not nice pictures are all mine. In early labor is 50.5. When it continued to be 50.5, even at full dilatation, 50 millimeters, then I knew this patient is not progressing and needed a cesarean section. Now, head direction is another thing. Angle formed by the longest visible axis of the fetal head with the pubic symphysis. Longest axis with the pubic symphysis. Head up means head is pointing upwards with regards to pubic axis. Now, you know the curve of Keres is down, horizontal and then up. That is a pelvic curve. So, if the head follows this direction, you know the progress in labor. If the head direction is downwards, you know it is still high. If it is horizontal, it is somewhere in mid-pelvis. And if the head direction is like this, head up, you know that it is well below the pelvis. Now, clinical application studies have shown that head perineum distance and angle of progression are more accurate than digital examination in predicting vaginal delivery in nulliparous women with prolonged first stage of labor. So, if the head perineum distance is more than 50 millimeters, even at full dilatation, you know that 82% of them are likely to land up in cesarean section. And similarly, if the angle of progression is less than 110 degrees, then you know that most of them will land up in cesarean section. Whenever there is a slow progress or arrest of labor in the second stage, if you see the alignment of the head direction, if it is head up, you know that she is going to deliver in the next couple of minutes. If it is head horizontal, still there is a good chance that she will deliver. But if it is still head down, that means the head is quite high and the chances of cesarean is much higher. Now, a comparison of digital examination with ultrasound for fetal position prior to instrumental delivery. Now, in instrumental delivery, knowing the fetal position is extremely important. How well the fetus is, the head is rotated, and what is the position of the fetus, what is the station of the fetal head is very important. This is the one which gives trouble and lands up in perinatal morbidity and all the obstetricians in the court sometime later. That is why many people have given up on instrumental delivery. Now, doing an ultrasound will help us, it will guide us, it will tell us whether the occiput is rotated completely, it will tell us exactly where to keep the place of vacuum cup. Error in correct assessment of fetal position can lead to deflexing placement of the vacuum cup, and that error can be avoided by by the intrapartum ultrasound. So, ascertainment of the fetal head position and station before instrumental vaginal delivery, there are many studies which have said that if the angle of progression is more than 120 and if there is head up, then the signs of successful instrumental delivery is very high. So, what else is there? This is just for your information. These are only studies that are going on. This is the cervical length for induction of labor. The odds of cesarean increases by 10% for every 1 millimeter increase over 2 centimeters. Posterior cervical angle is the angle between the mid-sagittal line in the cervical canal and a tangent on the posterior uterine wall. And the PCA more than 120 degrees is associated with a positive response to induction of labor. This will probably complement what Dr. Uma has been saying all morning about the success of induction of labor. Ultrasound pelvimetry is possible. You can get an obstetric conjugate with ultrasound. And dilatation of the cervix can be easily made out with ultrasound. I have not tried this, but you could perhaps try this. And slowly over a period of time, you will get to know how much dilatation even without actually doing a PV. Now, there are frequently asked questions about intrapartum ultrasound. Is it easy to learn intrapartum ultrasound? So there has been a study which has been done for that. Learning and accuracy of the determination of fetal head position in labor is easier and higher respectively with transabdominal sonography than even a digital examination. Does intrapartum ultrasound need special experience? No. Measurement of the angle of progression on transperineal ultrasound imaging is reliable regardless of the fetal head station or the clinician's level of ultrasound experience. Is it convenient for the patient? Yes, it is. It takes less than 5 minutes and is much more tolerable than a vaginal examination. Is 3D ultrasound better than 2D? Because now everybody is talking about 3D. Not necessarily, because 2D methods are simpler to learn and they can be analyzed quickly. And 2D equipment are preferred in the labor room. Does intrapartum ultrasound have predictive clinical value? That is what I have been talking all along, that when the angle of progression is more than 120, the probability of spontaneous vaginal delivery is very high. The shorter the head perineum distance, the shorter the time to deliver. Can it lower cesarean section rate? Not necessarily, but yes, in a way, because it is more objective use of instrumental delivery. So more people can do instrumental delivery than resorting to cesarean section. And by better assessment of progress of labor, yes, it can. Does it mean that we stop doing PVs? No. It just fine-tunes the clinical examination. It is superior to PV in difficult cases. So my dear friends, the way to get started is to quit talking and begin doing. And so I would invite all of you to start doing intrapartum ultrasound. Just write it on a paper and then, start using it, and you will think that, my God, it is so easy. Why didn't I use it all these days? We are moving from obstetric ultrasound to ultrasonographic obstetrics. Soon we will have sonopartogram. And by then, if we are equipped with this small skill of doing intrapartum ultrasound, it will go a long way. Thank you very much for a patient hearing.